To introduce our speaker is Binod Pant, who is a PhD student in our Applied Math, Statistics, and Scientific Computation program, and he's going to come up and introduce the speaker.
Hello. I'm introducing Dr. Abba Gumel. Dr. Gumel is a professor of mathematics, and Michael and Eugenia endowed chair in mathematics. He has been at UMD since fall of 2022, so recently started here. He's a mathematical biologist with various research interests in the field, including but not limited to impact of climate and environmental changes on vector-borne diseases such as malaria, dengue fever, and Zika, and impact of pharmaceutical and non-pharmaceutical interventions on the spread of various diseases such as COVID-19. He has been a recipient of many awards and honors. I will list some of his recent ones. He became Sciam Fellow in 2022. He's the 2021 winner of Belsman Prize, and in 2021 he was selected for Einstein Public Lecture by AMS, which is a public lecture given by one American mathematician once a year. So without any further delay, let me introduce you, Professor Gumel.
Thank you, Binod, for that very kind and generous introduction. And also, it's my honor to be invited to speak today at this Bioscience Day event. So, Binod is responsible for most of what I'll be talking about today, so he should be the one actually on stage giving the lecture, not me. The mathematics of COVID-19 pandemic describe some of the lessons that we've learned and ways I think we can mitigate the next one. Unfortunately, the question is when and not if we get hit with the next coronavirus pandemic. So that's the focus. So using mathematical approaches to understand the spread and control of infectious diseases. And this has a very long history, and I'm going to go into that. But the objective of the talk is to maybe present some mathematical models that can be used to gain some insight into the transmission dynamics and control of the pandemic, which is the greatest public health challenge humans have faced since the 1918-1919 pandemic. So over the last over 100 years, the biggest challenge we've had, a public health challenge. But again, the history of infectious, the mathematical modeling or mathematics in biology or in public health is a very long one. And before giving that history a little bit, I like to start the lecture usually with this slide showing us some burden of some of the deadliest infectious diseases that we as humans have faced. So smallpox killed over 300 million people in just the 19th century alone. Malaria used to kill 1 to 2 million people every year until about 2000, when we have this massive use of insecticide-based interventions, which drastically reduced the burden of malaria to about 500,000 to 600,000 a year, but mostly kids under the age of 5. Those are the ones that are dying of malaria. So HIV/AIDS, of course, has been around since the 1980s. 35 million people currently live, 38 million people currently live with the HIV/AIDS epidemic. TB used to be the greatest killer of mankind annually, 1.5 million deaths until the COVID-19 pandemic of 2019. There are other major outbreaks of infectious diseases, such as the flu pandemics we've experienced in the 1950s, 1960s, and 2009. The 2009 one was the H1N1 pandemic that started out of Mexico and the United States, the swine influenza pandemic. And then we had the 2014, 2016 Ebola outbreaks in 3 countries in Western Africa, Sierra Leone, Liberia, and Guinea, and the Zika outbreaks that Binod has mentioned earlier on. The point is that the number of disease outbreaks has been increasing almost by about 3 times each decade since the 1980s. And most of these diseases are originated from wild animals. So it's spillover events from animal populations to human populations. That has been the hallmark of these crossover events to humans. And the reason why I show this slide is to say that most of this are due to what we as humans do to destabilize the natural habitats of animals. And for example, through things like habitat destruction, through climate change, through environmental degradation and so on, bringing disease-carrying animals closer to human populations. So it is anthropogenic. This is largely based on our own actions that makes us vulnerable to outbreaks of emerging and re-emerging infectious disease. That's the point I'm making. And also globalization makes us more vulnerable to what's happening in faraway places. So those pandemics started from different places because of global travel, global trade, and so on, and we're all vulnerable to outbreaks. So we're all in this together, and we have to figure out ways to effectively control the spread of diseases. Like I said before, mathematics has always been influential, I think, in providing insight into biological processes, particularly public health. And the history of mathematics in biology or in public health dates back to perhaps the pioneering work of Daniel Bernoulli, right here, a physicist, mathematical physicist, a mathematician and physicist at the same time, who first provided a mathematical modeling approach to evaluate the potential effectiveness of immunization against smallpox. Smallpox is one of only 2 vaccine-preventable diseases that we have eradicated, the other one being rinderpest. So that was quite influential work. And then that leads to Sarono Rose, who elucidated the entire life cycle of the parasite that causes malaria, Plasmodium, and won the Nobel Prize in Medicine for that. But mathematically, we know Sarono Rose more for his determining the threshold theory of epidemics. So he designed the very first mathematical model for malaria, and his work led to the realization that you do not have to kill all mosquitoes to effectively control malaria. All you need to do is just bring the mosquito population below a certain threshold, and that is what was needed, for effective control. So that led to notions like basic reproduction number, and so on, which I'll talk about later. And then Carmack and McKendrick, those Scottish biochemists and epidemiologists, they actually laid the mathematical theory of epidemics. The point of all of this is at least 3 of the 4 are not mathematicians, but they are the most influential and laying the foundation. They are biologists, they are epidemiologists, they are biochemists. They laid the foundation for mathematical theory of epidemics. So that's the point I was trying to make. Okay, so we design mathematical models based on our understanding of the biological phenomena, and we use the mathematical models. Typically, if you have data, we fit the models as data and use that to make predictions, or at least to understand what is going on. So what is the actual role of mathematical modeling? Why do we do that? There are a number of reasons why we use models. Models, again, are approximation or representation of reality. We use models to test various theories, to assess various conjectures that public health people may have in terms of epidemics. And we can could provide insight into specific questions or determine sensitivities to changes in parameters, and also maybe estimate some of the parameters. I'll show some examples. We could also compare various control strategies. We can implement them, we can evaluate them, we can optimize them. We could also identify trends, using models to identify trends. What's the trajectory of the pandemic or the disease that's spreading in the population, and make a general forecast. Perhaps more importantly, public health people would like to get an early estimate of this quantity, this threshold, R0. R0 is the average number of new cases generated by a typical infected individual if introduced in a completely susceptible population. So if I'm infected, how many of you can I pass the disease to if none of you is infected before I get cured or before I die of the disease? That's what it means. Okay, so public health people, so typically if it's greater than 1, the disease typically persists in the population. If it's less than 1, the disease typically dies out. So that's a very important quantity to have in times of new epidemics. And disease burden, so how many people are likely going to get infected, how many are likely to develop severe disease, how many are likely to be hospitalized, and how many are likely to die, and that kind of thing. So that's very important. this makes mathematical modeling inherently multidisciplinary, right? We cannot do it alone. We have to understand the biology, therefore we work with biologists, public health people, with clinicians, with everybody, basically, to come up with good models that can be used to provide insight into biology. The ultimate objective, of course, is to use the mathematical modeling approaches to influence public health policy, to come up with good policies that can be used to effectively control and mitigate the burden of the disease that we're dealing with. Okay. So there are a wish list, of course, because this is a collaboration between mathematicians or mathematical scientists in general and public health people. So the public health people have their wish list in terms of epidemics. So like I mentioned before, early estimate of epidemiological threshold, like the basic reproduction number I just defined, the herd immunity threshold, I'll talk about that a little later, disease burden and so on. So a lot of wish lists that public health people would like to get insight into during early stages of an epidemic. Cost-benefit analysis, for example. If you have limited resources, how do you optimally allocate limited resources? We understand all of that in the context of vaccination against COVID. When we had vaccines at the beginning, we didn't have enough doses to go around. So how do we optimally allocate those limited resources to achieve maximum impact? Maximum impact in terms of minimizing cases, hospitalization, death, and so on. Okay, but we also have the mathematical wish list. So we design mathematical models, which are typically in terms of equations, mathematical equations. So we want to try to understand the qualitative features of those equations, of those models. So we have our mathematical wish list. So qualitative analysis, basically existence and asymptotic stability of solutions of the models at steady state. Those have non-trivial important consequences in determining conditions in parameter space that we can come up with some inequalities in parameter space that say if we satisfy these inequalities, the disease is likely to die out. But if you do not, then the disease is likely to persist. So that's the reason we do this qualitative analysis to characterize various bifurcations. Bifurcation is sudden change in the qualitative behavior of the system as you change a parameter. So typically, the value of the reproduction number is changed if it's a bifurcation parameter. If it's changing from 0 all the way to 1, we have one type of property or dynamic, but when it crosses 1, we have something else. The first one is elimination or extinction of the disease, and the second one is persistence of the disease. So as the value of R0 determines what actually the ultimate trajectory of the disease in relation to 1. R0 greater than 1, we have persistence of the disease typically. R0 less than 1, we have elimination of the disease. But we use a lot of data, so statistics is another major interest of ours in this kind of work. So we use data to fit the models, to estimate the unknown parameters of the model, and therefore we can use, by finding good estimates of the parameters of the model that we do not know for sure, we can then make reasonable predictions of what is likely to happen. So we can do uncertainty and sensitivity analysis. So uncertainty quantification is another major branch of statistics that's very useful in this kind of work. The reason is, to determine, what's the impact of not knowing precisely the values of some of the parameters of the model on the outcome of our simulations. So that's uncertainty quantification. And we have also computational interests, so we do large-scale simulation like models, like agent-based models, like network models, social network models, and so on. So again, it's a collaborative approach between mathematicians and public health people trying to provide insight into biological processes with the aim of formulating effective public health policy for controlling and mitigating the burden of infectious diseases. Okay, so I mentioned R0. It's always good to introduce this. R0 equals 2 means, on average, one typical infected individual transmits the disease to others. So if red is infected, black is susceptible, but susceptible, you are potentially target of getting infected by having effective contact with someone red. So this person, this is the index case, the very first case, so transmitted to others. This is a completely susceptible population, which means no one has prior immunity to the disease. No one has seen, just like COVID, during the early stages of 2020, January of 2020, only one person, the index case, brought the disease to the Bay Area. Before that, nobody else has seen the disease, nobody had immunity, so everybody else is in black. So one index case red, so if R0 was 2, that's red transmitted to others, this one transmitted to others, and so on. So before you know it, everybody becomes red in this case. No intervention is implemented, no control, no vaccination, no quarantine, no isolation, nothing. But another scenario is this, which is the control reproduction number. This is a scenario where you have the red, who's infected or infectious, And you have the blacks who are susceptible, but then you have blue, those are people with some prior immunity. Maybe they've been vaccinated or they've seen the disease before. So they are not equally as susceptible as those in black color. So this is called the control reproduction number. It's still 2. R0 is the reproduction number is still 2. But you have a mixture, a nice mixture of some people that are susceptible and some that are not. Okay. So that's a bit of background about R0. So this is an important quantity to compute. There are many different types of models, compartmental models, spatial model, agent-based, and so on. The type of model you choose depends on the type of problem you want to address and also the nature and the reliability of the data. For example, if you wanted to know who infected whom, then it makes a lot of sense to use the agent-based model. But most of our work is based on using the compartmental model approach. It tends to be suitable or at least reasonable for the kind of questions we're interested in addressing. So the simplest possible model for an epidemic, so an epidemic is a brand new disease that we have not seen before. Nobody had prior immunity. Therefore, one of the main assumptions made in the formulation of an epidemic model is that the time scale of this new disease, novel pathogen, just like COVID was at the beginning of 2020, is that the time scale of the new disease is assumed to be much smaller than the demographic time scale. Okay, therefore we do not include birth rate and death rate. So the only thing that can happen to a susceptible person is you can get infected by coming in contact with someone in the I class. So S is susceptible, I is infected, R is recovered. So if susceptible interacts with someone in I class, there's some probability that transmission can take place, and the probability depends on the number of contacts, how many contacts they have with that infected individual or infectious individual. So once infection takes, that's why it's negative. When infection takes place, it becomes positive, and then the infected person can recover at rate gamma and move to the recovered class. And once you recover, you have permanent immunity against future infection. This is the assumption here as well. You know, just like chickenpox, for example. Typically, if you recover from chickenpox, you don't get it again until much later in life. You develop shingles, that kind of thing. So anyway, so you see the susceptible population goes down, reaches a steady state. The infected population rate goes up, reaches a peak, and then comes down. And then pretty much most people acquire the disease and recover. So this is the basic Karmic-McKendrick model for infectious disease. It has no bifurcation. It has just one line of equilibria given by this. And the model was widely used, actually, to explain the plague in London, in Bombay, India, and the cholera in London as well, a long time ago. So I mentioned some of the assumptions. It's a closed population, so nobody leaves, nobody comes in. The population is well mixed, so everybody is equally likely to mix with everybody else in the population. Exponentially distributed waiting times and so on. So it's a simple model that can be used. In fact, this fits the data very well for COVID during the early stages of the pandemic, not later stages. It's only good the first few days, few weeks of infection. Yeah. So, but of course, it's extended, this basic model is extended to incorporate other heterogeneities such as age structure, race structure, spatial mixing, and so on. But that's the basic thing. Okay, anyway, so we're talking COVID. I'm not going to because we have a keynote on COVID, so I'm going to skip most of what I'm saying because Professor White is giving the keynote. But the timeline is, on end of December 2019, the Wuhan's public health officials informed the WHO of this emergence of a new pneumonia-like illness of unknown etiology. Nobody knows really where it came from. So it spread rapidly. The index case in the US was on the 20th of January of 2020. And by the 11th of March, the WHO declared it to be a global pandemic. And it has the usual symptoms of influenza-like illnesses and so on. It's all hidden here. But the point I want to highlight here, because the focus of my talk is really to look at the impact of some of the control measures that were implemented, especially before vaccines become available. So between spring of 2020 and early fall of 2020, the main interventions were mostly lockdown, social distancing, masking. The summer and the fall of 2020, also masking. And then the vaccines were approved or given emergency use authorization by the FDA in December of 2020. But before they really were widely used, it was maybe in the spring of 2021, March maybe. Anyway, so those are the ones. And I'm going to answer or try to address three main questions in this talk related to the three main interventions. So that's my objective here. And these are the data for cumulative mortality by country and other notables. And I'll leave this. I mentioned Sweden, Denmark, Finland, and Norway for a reason, especially for the grad students here. I would like them to let me know why I chose. Sweden had 20,000 people, over 20,000 people died of COVID in Sweden, but look at the data, mortality for the other Scandinavian countries combined does not match with that of Sweden. So that's a reason that I would like someone to ask or to talk about. Okay, so this COVID-19 has zoonotic origin, but not just COVID-19. MERS, SARS, Ebola also, even though we have no idea really exactly where it came from, but fruit bats especially are implicated as the main reservoir for Ebola, but it's question mark. These are mostly animals, so diseases circulating in animal populations somehow jump into humans through maybe a series of intermediate reservoirs. That's what happened with COVID. The SARS, the first one, came through severe cat to humans from bats, and MERS, Middle Eastern Respiratory Syndrome, which started out of Jordan and Saudi Arabia, is through camel to human, and so on. The 2009 swine flu pandemic started out of Mexico and the United States, and it's through the swine to humans. Again, it's consistent with what I said earlier. If we had left them alone, if we do not encourage their natural habitat, those diseases will only be spreading in the animal population, but not in human population. Anyway, so we've seen this COVID-19 is not the first coronavirus we've seen two others, and I'm just comparing them here. Basically, in terms of mortality and cases, confirmed cases, look at COVID is just very different from the other two. The other SARS, the first one, spread only to 29 countries, MERS to 27 countries. COVID-19 spread everywhere, causing all this. The only good thing about COVID-19 is it doesn't have the case fatality ratio of the other two. Case fatality ratio is proportion of infected people who ended up dying. Okay, so it's 1.1%. It was like 2% at the beginning, but then it decreased because of interventions and so on to 1.1%. What's the main difference between COVID-19 and the other two? Mostly is the role of asymptomatic and pre-symptomatic transmission. Asymptomatic, pre-symptomatic transmission is hugely influential in COVID-19, but not in the other two. Okay, that's the main difference. And of course, COVID-19 is more transmissible. It has higher R0 compared to the other two. Those are the two main differences. So the objective of our modeling approach is to assess the population level impacts of especially non-pharmaceutical interventions, not even pharmaceutical. Later on, I'll talk about vaccines, but that's been the main objective. Any questions so far? Okay, no questions, good. If there are any questions, Binod will answer them all. All the hard questions. I'll answer only the easy questions. Yeah. All right. Okay, so the simplest possible model I can come up with for COVID has this general structure. Again, it's an epidemic disease, so it's a brand new disease. We have not seen it before. Therefore, I will not have demographics. I will not have birth rate. I will not have death rate. It's just the dynamic of the disease. So S is susceptible, E is exposed. So mathematically, when we say exposed, it means you already have the disease, but you're not capable of transmitting it yet. Okay, so it's more like latent. You have the disease, but you're not infectious yet. Infected, but not infectious. But you can become infectious but pre-symptomatically, which means you do not display clinical symptoms of the disease, but you are capable of transmitting it to a susceptible person. So infection rate is lambda here given by this. This is like the force of infection, and it's a function of these betas. These are the transmission rates. Beta P, transmission rate for pre-symptomatic, beta A for asymptomatic, beta H for hospitalized symptomatic person, beta S is for the symptomatic individual. Okay, so we have four main routes of infection. There are four sets of infected people that can transmit the disease. Either those who are pre-symptomatically infectious, or those who are asymptomatically infectious, or those who are symptomatically infectious, or those in hospital. At the beginning, hospitalized people are also transmitting to their doctors and nurses and so on at the beginning, until we got better with how best to avoid getting infected in the healthcare system. Anyway, so infectious, so this is a chain. So S gets infected at the rate lambda, which is given by this. And once you're in the E class, so there's a time lag 1 over sigma E, within which you move from E to the infection to the pre-symptomatic stage. Now, at the end of the incubation period, or when you or the duration in the pre-symptomatic stage, a proportion R would show symptoms at the rate sigma p. The remaining proportion 1 minus R will not, will become asymptomatic and move to IA, and they can recover at the rate gamma A, the other ones gamma S and gamma H, respectively. Okay, so that's the simplest possible model, and the equations based on this flow diagram is given by this. Dot means differentiation or derivative with respect to time. So this is basically, but again, lambda is nonlinear is given here so that the model is nonlinear. Yeah. So many of these parameters we know for sure. We know the values from hospital data, epidemiological data, and so on. Some of the ones we do not really know are like the betas, the transmission parameters, and maybe disease-induced mortality, delta S, delta H, or disease-induced mortality. And those are the ones we use initial data to estimate. That's one of the things. That's why statistics comes in. Okay. So in order for us to calculate R naught and make predictions as to the burden of the disease or how best to control the disease, we need to be able to know precisely the value of each and every parameter of the model. Many of them we know for sure, but some of them, particularly the betas, we do not know. So we fit the model, use any optimizer that we have, least squares, or particularly for the students. That's why it's so what you learn in linear algebra classes when doing optimization, least squares, is very important because we apply that here straight away. The same idea. Sometimes we use more advanced technique, but it's still the same principle, the same idea, to find the best values of these unknown parameters for which the data and the model are nearly identical. Okay, so we do that. Okay, so having this model, if it's parameterized, it's fitted with data, and the Johns Hopkins University database actually has maintained really excellent collection of COVID data for pretty much every part of the world, particularly here in the US. So we use that. But one of the first questions I want to address is what's the impact of community lockdown? Because that's the first thing we did. And interested, at the time we did this work, I was in Arizona, so naturally I chose the state of Arizona. So we went on lockdown on the 31st of March. The first case, the index case, was detected on the 6th of March. This is for Florida, first case on March the 1st, went on lockdown on April 3rd, and New York, with the epicenter of COVID at the time, the first case was March 1st, went on lockdown March 22nd, stayed in lockdown until May 28th. That's the reason. This is very important. New York was very quick to get into lockdown and stayed in lockdown longer than everybody else. That's very important to note. So I'm coming back to this point. So we fitted this model. Okay, so we fitted this model using cumulative mortality data. That's also another reason we use cumulative mortality. It's more reliable than the case data. The reason is, again, we do not have good handle of asymptomatic and pre-symptomatic transmission, and I'm going to show later on that they are the main drivers of the epidemic, actually. Just both before lockdown, pre-lockdown, and during lockdown. We're not testing widely. If we're testing widely, then we can detect asymptomatic and pre-symptomatic, but we're not doing that a lot, so we had no idea. The reported cases were grossly underestimating the actual burden of the disease. That was, even the CDC acknowledged that, I think, much later. Okay, so anyway, this is pre-lockdown period and lockdown period. So we fitted the model for both pre-lockdown and lockdown period, and to show that a reasonably good fit, this is for the pre-lockdown period for, this is Arizona, Florida, New York State, and the whole of US. You see the blue is the model, red is the data, and this is the cumulative mortality. We're plotting cumulative mortality also for during the lockdown period. So the top panel, pre-lockdown, bottom panel lockdown. The reason we did this is very important. It gives us a proof of concept to show that, okay, the model is reliable. We can now, because it matches the data reasonably well, then we can use it to make predictions. So the fitting was reasonably good. And based on this fitting, we obtained the best values of those 4 parameters that we didn't know before, beta, p, beta, and so on. So we estimated parameters from fitting. The way to test whether our parameter estimation was good or our fitting was good is now to use the fitted parameters plus the baseline parameters that we know for sure from hospital data and so on, then to try to see, to match what our model says with what the observed daily cases, not cumulative cases. Okay, so we use the model to make predictions now and match the predictions with the actual data. That's what we did in the next slide. And you see that this is, the red is again the actual data for daily death, and the blue is what our predictions from the model that we just fitted, and it looks reasonable for all 4 jurisdictions. Okay, so based on that, we calculated, we were able to do a basic back of the envelope calculation to see, okay, what is the relative contribution of pre-symptomatic individuals in generating new infections in the state of Arizona before the lockdown period. We showed us about 47%, asymptomatic 19%. So pre-lockdown in Arizona, these are the main drivers in Arizona. Same in Florida, the same across the board. They are the ones generating new cases, just based on the fitted values of those betas, those transmission rates that we've seen. So clearly, that's the first result we got on our COVID modeling, that the main drivers of the epidemic were people who had no idea they have the disease, pre-symptomatic and asymptomatic people, based on the data that we had, the initial. So asymptomatic, and okay, so this influences what intervention needs to be implemented, right? Because if the people spreading the disease are people who have no idea, and there's no way we can know them because they are not reported to the public health system. The public health system is not aware of them. We cannot track. The only way to keep track of them is to do random wide-scale testing. That's the only way you can detect someone who's asymptomatic or pre-symptomatic. So that's the strategy we mentioned in this paper. This paper came out, I think, we wrote it in April of 2020, and it came out probably in August. Yeah, that's the thing. So we are saying, we're advocating right from day one, okay, testing, followed by contact tracing of those confirmed cases, okay, through testing. And that was the best strategy at the time that we were advocating. It's still useful even now. I think even now, some of these numbers still hold. The main drivers are still asymptomatic, pre-symptomatic. But I think the keynote speaker will highlight some more on this. Okay. Then we made predictions, but because of time, I think I'll probably... so this light blue is the shaded region for when we are in lockdown. So this is for Arizona, this is for Florida, this is for New York, this is for the whole of the United States. And so red here means if reopening, so I showed the table when various jurisdictions reopened, lifted their lockdown period, okay? So, and we had 3 different levels. It's high lifting, moderate lifting, and basically high lifting meaning basically just say, okay, you're not in lockdown, you can do whatever you want, you can go to a restaurant, you don't have to mask up, so that, anyway. So most of the jurisdictions actually did something like that, and we predicted around, when we wrote the paper, that Arizona is likely going to be hit with really devastating second wave around this time, which is sometimes in the fall of 2020. And the same thing with Florida, not New York. The reason simply because they went in lockdown first and they stayed longer. See what we're predicting. It's very mild second wave. But then this whole of US, this is almost exactly what happened actually. We said if everything remains the same, we're going to be hit. I got in trouble actually with some of the media people saying we're predicting disaster or doomsday, but the data doesn't lie. That's exactly what happened, unfortunately. We were saying if everything was kept as before during the lockdown, immediately after the lockdown, if we do not get our act together, this is what we're going to be hit with. Yeah, and it happened. Okay, so what's the impact of early implementation of lockdown measures? Suppose we went on lockdown like a week earlier or 2 weeks earlier. So a week before the lockdown period, if you check the data I showed before, in the state of New York, there are only 10 deaths, but a week before. But during the week of the lockdown, it skyrocketed to about 700. So at that time, a week before, 2 weeks before, we were not at the exponential pace of the disease yet. So imagine if we started locking down around that time, we'd be able to, and that's what we tested here. So magenta, so this blue line is, this shaded region is the lockdown period for, this is Arizona, this is Florida, this is for New York, this is for the whole of US. And the magenta line is if we started lockdown a week earlier than we did in Arizona, this is what would have, and the blue is what our model says using baseline levels of parameters, and red is the data. The baseline, of course, matches the data reasonably well, but this is what would have happened if the lockdown was a week earlier, based on our simulations. Much milder, much milder epidemic in Arizona, much milder in Florida, and almost no epidemic in New York. And the same here. And if we started 2 weeks earlier, again, much, look at what's happening. Basically nothing. Green, and so on. These are the cumulative numbers. So early, just starting a week earlier, 2 weeks earlier, hit hard and hit early, hitting the pandemic early before it is on that exponential. If it's in that exponential phase, then you don't have a week to waste. You don't have 2 weeks to wait. Then you're playing catch up, and it's just impossible. The spread rate is essentially e to the R naught t times some scaling constant. So R naught was already estimated for COVID at the beginning to be between 3 and 4. That's what Neil Ferguson's group, Imperial College, estimated. Many other modeling groups also estimated similar numbers. So if it's spreading at rate e to the 3t, for example, within a week you can imagine how many cases. And it was highly fatal. A lot of people are dying. So that's what explains the devastating numbers at the early stages, at the exponential phase of the disease. So you want to hit the disease epidemic, novel disease, early and hit it hard. Suppress it before it engages or it gets into the exponential phase. So that's the conclusion number 3. Early implementation of effective lockdown measures, a week or 2 earlier, could have significantly suppressed the pandemic. Hit hard, hit early. And by so doing, the community transmission is so low in that case. Therefore, the likelihood of the emergence of new variants is almost gone. Because the reason we have variants is because of large level of community transmission. Therefore, variants are consequences of mistakes happening in the replication process in the body of somebody infected. If there are more of us infected every day, like 1 million or 2 million, then of course there's more likelihood of mistakes. But if we have suppressed it to only, as Dr. Anthony Fauci was saying, the best for us in the US, for example, is to bring the number of community transmission daily to maybe no more than 10,000. Then 10,000, then less likely to have mistakes, mutations that could lead to deadly variants like Omicron, like Delta, and so on. Okay, and then now we want to do objective 2, masking. So what I've shown so far is the only control strategy is lockdown, if that's all we have. Just like they did in Wuhan city, they showed to the world, they proved to the world by getting into lockdown quickly and staying longer. They stayed in lockdown for like 75 days or 85 days, I can't remember exactly. And how many cases in Wuhan? Almost 0 during that time. So hitting things hard and hitting early will save lives. If we had done that, so if the only thing we have going for us is lockdown, if we do nothing else, for example, that could have worked also. Could have saved us time until we get a vaccine and then we don't have to lock down again. So the next one is, okay, suppose masking is all we have. We don't have to lock down, but we have masks. Okay, is that possible to effectively control this pandemic using masks alone? So we modified the model to include masks. The model I've showed you doesn't have masks, so we just made some slight modification. And we fitted the data for the 3 waves that we have experienced in the US, starting from the beginning, the 20th of January 2020, all the way to the spring of 2021. This is first wave, second wave, third wave. And you see red is data, blue is the model. It looks reasonable, and we made predictions. And that's what also happened. After the third wave, we have more cases. Sorry, this is cumulative. This is daily cases. So after the third wave, we predicted going down daily cases. And I think that's what happened also, until Delta came to town and then something else. Anyway, so this is a model with masking, and we fitted it nicely for the 3 waves. It wasn't easy, but this was done by grad students, so that's really nice. Okay, so now we want to answer a few questions, a few key questions. So this is a very rich slide, but I will explain. This dotted line is here. So the dotted line is the onset of mask use strategy. Okay, that's when we suppose. So for A, suppose we started mask use strategy on March 15th. March 15th is an important day, okay? So it's like 4 days after the World Health Organization declared COVID to be global pandemic, okay? So suppose we have stockpiled masks and make them available. The minute the World Health Organization says, okay, we're dealing with a global pandemic, let's say it takes 4 days to agree, the CDC, okay, everybody, when you go in public, wear a mask. And we're considering 4 different types of masks. The cloth mask, just the basic one, not like this one. Then the improved one. So I'm just going to distinguish them based on the efficacy. So efficacy to protect. So a mask has 2 main efficacies, right? The inward efficacy, if I'm susceptible of wearing a mask, what is the probability of the mask protecting me from getting infected if I'm within 6 feet of somebody who is infected? So that's the inward efficacy. And then there's also source control, so the outward efficacy. If I'm infected wearing a mask, what is the probability the mask will stop me from transmitting the disease to somebody who is not infected, so susceptible person. So red is the data, blue is the baseline, so we parameterize the model as baseline parameters, so everything is nice, it fits the data very well. And this is, this dash solid line is the end of the first wave, so in all of the plots. So the dotted line is the beginning of when you implement your masking strategy. For A and D, this one is when we started 4 days earlier. 4 days after the WHO had declared it to be a global pandemic. So see what's happening. So on the day that, at the end of so we're comparing at the end of the first wave, which is this particular day, I think sometimes end of June of 2020. Anyway, so this is the actual number. This is what would have happened, what the mortality would have been, the cumulative mortality would have been if everybody else, about 80%, okay, we are also making the best case scenario that 80% compliance in masking. So 8 in 10 people that go out in public wear a mask of various efficacies. Of course, that's not feasible, but the best case scenario, in a very optimistic scenario. So that's the case. If you wear this cloth mask, is 30% efficacy. It's not doing much. 50% efficacy is right here. The surgical mask, this one's 70% efficacy right here. But look at this, N95 respirators right here. This is what would have happened compared to this number. A huge reduction, about 84% reduction in mortality, cumulative mortality. If 80% of us, starting from 4 days after WHO said this is a global pandemic, 80% of us, when we go out, we wear N95, not this one, N95, yeah, like yours, Eric's one, yeah. So, and this one, okay, so it's still, there will still be appreciable epidemic. This is for the whole of the US, we're right here. So there'll still be a number of people dying, a significant number of people dying, but not compared to the baseline, which is right here. But this panel here, this is, if we started, what is it? So this is February, we started February 18th, that is 1 month after the first case in the United States. If we started masking, so the first case was introduced January 20th, 2020 in the Bay Area. If we do nothing until a month later, and then we agree to mask up a month later, this is what would have happened. This is, again, what happened. This was the observed data on that day at the end of the first wave, okay? And this is what happened if you use, say, the lowest quality mask. This is the improved mask. This is the surgical mask, and this is the, so this is the N95 mask. See what happened? We basically will have suppressed the epidemic if 80% of people are wearing N95 masks. Even a month later, we have a window of opportunity. 1 month, we can delay for a month based on our simulations. If you delay it for a month, but everybody is wearing N95 mask, the disease has basically no chance to take off. But if it's a surgical mask, it takes off, but it's a milder epidemic compared to what actually happened. Okay, so there are also masks, right? The type of mask we use, the quality, if we use a moderately to highly effective mask, we would have suppressed the pandemic. So, and the same here, this is even better. Okay, so this, so this is February 2nd, this is just 2 weeks after the index case. If we started masking up 2 weeks after the index case, this is what would have happened. See, right here, basically it's green, it's N95 mask. This one also surgical mask. They do much better. The two are separating themselves from the other three masks. So what this means is we stockpile high quality masks like this ones, like N95 masks, make them available during the next pandemic. We'll buy ourselves time before we get a vaccine. This is what this study shows. This is what other studies also have shown clearly. Okay, so this is, okay, so if we started March 15th, we'll have saved 84% of the 128,000 people that died on that day, the end of the first wave. By the end of the first wave on that day, that's June 3rd, we already lost 128,000 people in the United States. So we would have saved about 80% of those if we started masking up March 15th, 4 days after WHO said this is a global pandemic. We would have saved a lot of this. These people didn't have to die if we had masked up. But of course, it was a highly optimistic scenario of 80% compliance, which is very difficult to achieve. Yeah. So, and then the other mask type also will have some reduction, but much smaller than the N95 mask. Okay. So this is the conclusion. Early implementation of masking strategy using highly effective masks with high compliance would have resulted in a huge reduction in the pandemic burden, would have actually suppressed the epidemic. If we apply 2 weeks earlier, or 2 months earlier, the pandemic would probably have failed to take off if we're prioritizing the use of N95 masks compared to the other types of masks. So masking alone could have suppressed the pandemic if we use a high quality mask with high enough compliance. That's what this and maybe related studies also have shown. Okay, and then the game-changing moment. I have a few minutes to quickly go through that. So this, grandmother was the first human to get vaccinated in the United Kingdom, in the whole world actually, on the 12th of December, 8th of December, 2020, and that's a great moment for us. So it's a game-changing moment. So the discovery of these mRNA vaccines was good, but the work to set up the mRNA vaccine, the work on developing the platform has been going on for decades, actually. So, but anyway, there's great progress made to do this. Different types of vaccines that were approved or given emergency use authorization by the FDA, okay, and then the boosters and so on. So all of these details we know, but those are the ones that are being used in the United States. And AstraZeneca, I think, has not been used in the US. It's used in many parts of the world, but not in the US yet. But those are the ones that have been used. So they save life. They have been proven to have huge efficacy in severity of disease, in hospitalization, in reducing severity of the disease, hospitalization, and death. So, and also preventing people from transmitting infection. Okay, and this, of course, variants emerge. Again, this is directly correlated with the level of community transmission. The community transmission goes up, we have more likelihood of variants. These are some of the main variants. But I highlight mostly Delta and Omicron being the deadliest. And this is the data for the US showing this Delta. When Delta hits, it was the biggest game in town, and then suddenly Omicron came and displaced Delta, basically. So that's competitive exclusion that the data clearly shows, and our modeling also clearly showed the competitive exclusion process. So the strain or the variant with higher reproduction number typically dominates the other one and sometimes drives it to extinction, and that's what exactly happened. Right now, almost all the cases we see are Omicron. We don't really see Delta. And these are the mortality data for the US, and this is the case data in blue. Herd immunity, so I don't know if I have time to go through so basically herd immunity is ability to protect those that we cannot vaccinate. When you have a vaccine-preventable disease, when you have a really good, safe, and effective vaccine, you cannot vaccinate everybody, unfortunately, for so many different reasons. So what's the minimum proportion of those that can be vaccinated that we need to vaccinate so that we can protect those that cannot be vaccinated? So this is like a completely vulnerable population. So blue as acceptable red. So every blue is surrounded by a sea of red. Of course, it's just a matter of time before they get infected. But if we have a protected community, a community that has reached herd immunity, so some of the blues are shielded by a sea of greens, and that protects them from the red, So the red will have to infect these guys, but they have partial immunity, so the red cannot really get into this green. Therefore, this blue is safe. I mean, that's the notion of herd immunity. That's what it means. Okay, so what's the minimum? So we have these excellent vaccines: Pfizer, Moderna, Johnson & Johnson, and now Novavax. Okay, what's the minimum proportion of the United States population that we need to vaccinate to achieve herd immunity? And herd immunity is the fastest and safest way vaccination is the safest and fastest way to achieve herd immunity. Anyway, so a simple model for vaccination, which has this form, is just similar to the previous one, only that we added another compartment for susceptible vaccinated people, and we have the efficacy of the vaccines right here, but everything else basically the same. But because we're vaccinating kids, so here we have to add demographic. And besides, at the time we did this work, it was already established that the strategy towards COVID now is just learn to live with it. COVID is here to stay. It's going to be an endemic disease. It's no longer an epidemic. That, I think, is the general mindset people have now. It's going to be maybe more seasonal than. So we added demographics. That we fitted the model right here. So, and in fact, what we had data. We withheld the data for 1 month and then we use that for cross-validation. So blue is the model, red is the data, and the green part is to cross-validate. So we already had the data, but we wanted to see whether our model is trained to capture that, and it did, and then we use it to make predictions. And based on the prediction, we showed that the daily case actually is going down. This is the general trend right here. This is for the cumulative cases. Okay, so early implementation of vaccinations program using this highly efficacious Pfizer and Moderna vaccines with efficacy about 94% would have suppressed the pandemic here also. This is right here. This is what our prediction shows. By March of 2022, this disease is basically gone it's basically suppressed right here. Yeah, so this is how to calculate the herd immunity threshold, HIT. First, we calculate the reproduction number, the control reproduction number, which is the spectral radius, is the dominant eigenvalue of some matrix in magnitude. It's given by this R naught is the basic reproduction number, epsilon V is the efficacy of the vaccine, FV is the proportion of individuals fully vaccinated with either Pfizer or Moderna vaccine. So we just solve for FV from here, and then that's the threshold, that's a classical expression for herd immunity. So if we know the value of R naught, we know the efficacy of the vaccine, we can calculate this. So based on the data at the time, our calculation shows that the efficacy, the herd immunity threshold is about 68% for the United States. We need 68% to be fully vaccinated in order for us to achieve herd immunity, which was, right now, is almost around that. So it's about 68% fully vaccinated and boosted, most of them were boosted. But the expression for herd immunity is more complicated. We wrote a paper here in Journal of Mathematics showing that it's more complicated if you do not make the homogeneous mixing assumption. All the models I talked about so far have this underlying homogeneous mixing assumption. Everybody is equally likely to mix with everybody else. In reality, that's not true. There's a heterogeneity, inherent heterogeneity. So case, maybe it's based on age or based on risk, based on many other factors. So you're not more likely to mix with everybody else. So if we allow some heterogeneity, the expression for herd immunity is more complicated. In fact, the value is lower. This paper in Science, actually, Tom Breton actually showed that the requirement for herd immunity is lower. It's not going to be 68% in this case, lower than that if we allow for heterogeneity. But it's not easy to do, so I'd like some of the grad students to do some of the proofs. And this I'll skip. I'll skip this one too. And because of time, it's already 50 minutes. Yeah, I'll skip some of this. Vaccination at different mask type, we do better with high quality masks, N95 mask green, surgical masks in yellow, and so on. We do much better. If you combine masking and vaccination with high quality masks, you accelerate the time to elimination. Look at the time to elimination is predicted to be around May 28th of 2022, this year. So basically, which is pretty much what is happening, although we're seeing some kind of rebound nowadays, but this is what we have. If you combine vaccination with masking, with all the mask types actually, we're predicting elimination. Okay, so let me conclude. Yeah, this I'll skip also, Omicron, Delta. We show the reproduction number for Delta is lower than that of Omicron. Omicron is 0.96, so clearly the one with higher reproduction number drives the other to extinction in this case, and the data showed that Omicron, and even for Omicron, it's just around 1. If it's greater than 1, it persists. Around 1 is just about, it's on its way out also. That's what we showed. So, okay. So let me conclude. Early implementation of non-pharmaceutical interventions could have curtailed the pandemic effectively. Lockdown measures implemented a week or two earlier would have done the job. Masking strategies that emphasize this guys and N95 mask would have done the job also. Will have saved us time, buy us time before we get a vaccine for the year. If I wouldn't even have to, I claim we wouldn't even have to shut down the economy if we were having this masking strategy based on this and N95 mask. If 80% of us will wear this and there was no need, based on our study, to lock down. There was no need to shut down the economy. We can still be, so for the next pandemic, stockpile these guys, make them available right from day one. We didn't have to shut down. We wouldn't have to shut down. So how to mitigate the next pandemic? Again, it's a question of when, not if. How do we do that? These are some of my thoughts. So first, address the problem from the grassroots, okay? From the source. So mitigate our own actions. So we as humans have to stop doing the sort of thing that we're doing that making us vulnerable to. So stop messing around with the natural habitats of non-human primates. Stop this wildlife farming and so on. So all of this is anthropogenic climate change, environmental degradation, all of those things we stop those, we take really serious effort to mitigate those, then we have a chance to minimize the chances of new pandemics emerging. Otherwise, it's a question of when, not if. Okay, so ramp up genomic surveillance. Okay, South Africans did a fantastic job in telling us about Omicron. That probably saved a lot of lives very quickly. So we need to be constantly, not just in South Africa, not just in the United States and the United Kingdom and Germany. We have to be doing it across the world. Israel also did a fantastic job with genomic surveillance. We need to be doing that constantly to know what diseases are spreading in human populations so that we're able to detect them very quickly and implement the strategies that need to be implemented before they become a big problem. So genomic surveillance for early detection of respiratory pathogens is very critical. We don't have a choice. We have to be doing this constantly, taking blood samples randomly and testing to see people volunteering to allow that, because it's in our best interest to do that, to see what's happening before they become a big problem. So stockpile and make early deployment of highly effective masks, particularly N95 masks, or equivalent. So there's equivalent KN95 in China, the SF94 in Korea. So that's very useful. Stockpile them, make them available on day one. The minute the WHO says there's a pandemic, make them available. Of respiratory disease, make them available. Early implementation, effective control measures. No, I'm coming back to that. Improve the efficacy of these mRNA vaccines development platform so that it took a year to develop them, but if we can accelerate that, make them available within 6 months, because all of these are band-aid measures, so we can save ourselves time until the vaccine. The vaccines are really the game changers. So you vaccinate people, then we don't need to wear a mask, really. I mean, so we can buy ourselves time by doing that, but it's good to expedite the process of the platform for developing these highly effective and safe vaccines. So implement the hit hard, hit early NPI, non-pharmaceutical intervention-based strategy, aim at suppressing community transmission. By so doing, you minimize the chances for the emergence or re-emergence of variants. Provide some economic incentives to, remember the story of the meat factory workers, who they had to go to work because that's the only way to sustain the livelihoods of their families. Suppose, and they couldn't observe quarantine, even though they were told to stay in quarantine, but how can they feed their family? So if we're able to provide them incentives so that they can stay home, then that will be extremely effective. So provide some incentives, economic incentives to the most vulnerable in society so they don't get exposed to the infection and death. One health approach to public health. It has to be about global change. It has to be looking at public health holistically, not just the health of humans. No, the health of humans, the environment, and the animals, and how we collectively, animals and the environment and humans, affect the environment. We have to look at public health in this holistic, one health, global change kind of approach. And doing all this and hope that the next one does not have the high transmissibility of Omicron and the fatality of Delta. Doing all of this will not save us from maybe the first one if we really pay attention to global change, climate change, and so on. But most likely, we're still going to be hit with the pandemics. And this is the picture I always like to capture the whole story. Keeping tabs on zoonotic. All of this is our own actions that makes us vulnerable to deadly infectious diseases until we get our act together. Again, it's a question of if and not when. Sorry, it's a question of when, not if. And I will stop here, and I thank you for your time.
Thank you. If there are any questions, we'll take a few questions and then change over to our third talk. There's a microphone in the middle if somebody wants to address a question. Don't be shy. I left modeling in 1982, and I still understood.
Yeah, very good. Karen.
Very nice, Abba.
Thank you, Karen.
Did you include anything in your modeling having to do with transmission between different countries? And can you say anything about preventing travel between different countries?
Yeah, excellent question. Yeah, so in the model, no, we didn't. But in the separate study, Vinod was one of the lead authors in that. We look at, especially during the early stages of Delta. Delta started from India but Pakistan is next door. So we're interested in looking at what's the impact of huge number of cases and mortality due to Delta on the potential dynamics in Pakistan. So because there's mobility between so we consider them like it's called spatial model or meta-population model. So we did that. Yeah, so what is the impact of shutting down airports? Absolutely, there's quite a number of studies, not my studies, but other studies that have shown that has proven to be extremely effective in curtailing the spread of the pandemic. Yes, that's very good. But we did a paper which shows the impact of mobility between Pakistan and India during Delta, that it was very effective to consider that shutting down borders and so on at that particular time. Yeah, it depends on the value of R naught. If R naught is very high, then yes, shutting down airports and borders is extremely effective. But if R naught is not as high, then may not be terribly cost effective if we are able to isolate those with clinical symptoms. So if people come into the airport, they're testing at the airport at point of entry to make sure they measure your temperature to see if you have high fever, then they isolate you, then you stay in the airport for a few days, for example. Australians have done that quite effectively, but I know controversially as well. So they detain people at airports anyway. But yeah, that's a very good question, yes. Thank you.
We as scientists are used to seeing data presented as charts and graphs, equations, that doesn't frighten us.
Good.
But I don't know what your experience has been, but some of the people who are essential decision makers in society, frankly, have had very little science, very little of CMNS gets there. So just curious as to what your experience has been and how your community, if you will, would do it differently the next time.
Oh, that's a great question. How do we do it the next time? First of all, yeah, so communicating these ideas, these concepts and results to public policy people. The public health people, yeah, they understand this language, and because they have been doing it. So the public health people are the ones who started the mathematical theory of epidemic, for example. So it's easy to communicate with public health people, with medical people, with the likes of Dr. Anthony Fauci and so on. It's the politicians sometimes that's difficult to communicate across if the messaging is not consistent with what they want to hear. I mean, that had happened during Ebola outbreaks, for example, in the 3 countries, in Liberia, Sierra Leone, and Guinea. The same during COVID here as well. There's this epidemic of misinformation and disinformation that's going on, and it's very difficult to convince people that have made up their mind on certain things. But the data doesn't lie, science doesn't lie. Yes, we lost 1 million people. They didn't have to die. So the same thing, our predictions for Arizona and Florida and the whole United States. We said, if we continue doing what we're doing, this is what would happen. It happened. We're not the only ones who made those predictions, and they happened. Other people also have made it. But yeah, how do we do it differently? We have to stick to science. We have to keep saying this is what the science says, and hopefully we change the tide and politicians will begin to listen. But yeah, for COVID, during H1N1 to 2009, we didn't have this stigmatization or politicization of pandemic. No. In fact, we didn't even have to wear a mask. There was no controversy, and it was dealt with effectively. But it was COVID, somehow it became a problem. But yeah, we have to be patient. We are scientists, we have to continue to be patient, but we stick to science. We're driven by what the data says, what the science says. And I don't think we should apologize to anyone, for what the science says. We try to get it right. I mean, some of us got some things wrong, but the beauty of science is we learn from our mistakes and we try to get better all the time. So, but communicating, and it's important because we have to communicate to policy people. They are the ones to make decisions. How do we effectively work with them? We have to be patient and we have to continue to do that. But there are some success stories, some places that have done really well in working effectively. I think the United Kingdom is a good example. I think the modelers and the government work really well together. I think at some extent Australia, I would say they had some good collaboration. South Africa also. Yeah, but that's a great question. Yeah, thanks.
Last question.
So the United States probably has had the highest vaccination rate. And in spite of that, we also seem to have had the highest death rate. And that sort of needs an explanation. Now, we know that if people's immune system is good, uh, they don't die as often. If their immune system is bad, they die more often from these diseases, which is one reason that Scotland and England send out bottles of vitamin D to the population. So one question is, I mean, suppose the United States had sent out bottles of multivitamins and zinc to everybody. How would that change things?
Yeah, so nutrition, yeah. So what's the question is what's the impact of nutrition, improved nutrition on the likelihood of people getting COVID and dying of COVID, right?
And the other thing is that there are previous drugs that could have been, repurposed or used when people get sick, before they get to the hospital. And there was no attempt really to do that in the United States. It did happen in Peru, where they sent people actually door to door to check on the population and to check on families. And when people were sick, they gave them ivermectin and a few other things. And it knocked the death rate down by a factor of 14 until there was a change of president who said, stop giving out ivermectin, and made it difficult. And then the death rate went up by a factor of 10. And similarly, somewhat similarly, there's a big state in India with 200+ million people, Uttar Pradesh or something like that. And they also sent teams around the country, around their state, but it's a big state. And if when somebody was sick, they were handing out ivermectin and I think it was doxycycline and zinc, and they destroyed the COVID in their state.
Yeah, no, I think that's a very good question. Actually, it's for the antivirals. Yes, I think the FDA has given emergency use authorization for 2 antivirals in the U.S. last year, I think, and some have been used quite effectively for people, but they were very, short supply. I mean, we didn't have enough of those, but it's prioritized only for people with severe disease, right? It was people who are more likely to die. The ivermectin is easily available.
4 billion doses of ivermectin have been given out to people before the pandemic.
It doesn't work? No, it hasn't. Okay, but you asked a question, Jerry. I like the last part of the question. We can discuss this later on. The last part of the question related to if the United States gave vitamins and other things I will relate it to vaccines. Because we have a lot of vaccines here. What's the impact of, if we're not vaccinated? So we may control the disease here, but the fact that it's a respiratory disease and we're all connected by mobility, the fact that the disease is spreading in other parts of the world that is not heavily vaccinated, you mentioned India, Pakistan, all the Indonesia, big countries, so it's only a matter of time before we get another outbreak in the same, as long as we allow for mobility. So it's in our best interest also to allow these resources to be made available to places that cannot afford them. It's in our best interest. So I like that part. Yeah, it's a very good point. Anyway.
Okay, thank you, Dr. Gumel. We're going to switch over between speakers and continue with our last speaker.
Okay, thank you.